Hello, my name is Clive Kay, Chief Executive Bradford Teaching Hospitals. I and my colleagues here are going to present to you on behalf of the West Yorkshire Association of Acute Trusts, or WYATT. We had considered adding to the title Emerging Alliance of Radical Providers, or ERP, but in the end we decided to keep it a straightforward WYATT. So I hope the following presentation is going to provide you with three key messages. What we, as an association of 6 acute trusts, intend to achieve in terms of ambition for our patients. 2, why we would be a good choice as an acute care collaboration vanguard, and also what support we would need and our commitment to the vanguard process if selected. So without further ado, I intend to ask each of my colleagues here in height order a question in terms of what WYATT stands for. So my first question is to Owen Williams, Chief Executive, Calderdale and Huddersfield Foundation Trust. Owen, what is special about WYATT and why is this vanguard so important?
Thanks, Clive. Well, first of all, the reason why we are here fundamentally is that we know that within West Yorkshire we have, without a shadow of a doubt, some of the hardest challenges around health inequality amongst the country, and that's what we're about. We've got a population of around 2.35 million that is scheduled to go up to about 2.47 million by 2025. So we know that we're challenged, and we know that the status quo as far as those local people are concerned is no longer tenable. WYATT for us, forgive the analogy, the patient talked about not using analogies, the West Yorkshire Association of Acute Trusts, what it's about for us is a combination of 39,000 colleagues working together across the footprint that I've just described. We will be working very closely with 10 clinical commissioning groups to co-produce where we're trying to get to and arrive at the same place. And we'll also be working with West Yorkshire Joint Overview and Scrutiny as well, because having local government involved in this is really important, particularly for the matters that relate to social care. Vanguard status is really important to us because we believe it's a galvanising effect. It's something that when we can talk about ourselves as being a vanguard bid and having regard nationally, we think that that really drives impetus and pace into moving us forward. And for us, 3 key areas that we're looking to really talk about. One about strong horizontal clinical networks, but again I think really important to talk about those being co-produced with clinicians and patients, not an either or as far as we're concerned. A shared approach to workforce and organisational development, that's also about the deployment of clinicians, for example, but it's also about how we act, how our values and behaviours become common. And then perhaps really important and significantly, and Stacey will cover this I'm sure, enhanced and seamless patient experience, which is really driven through really creative use of technology.
Owen, thank you. So I'd like to ask Stacey now. So Stacey Hunter, Chief Operating Officer, Airedale Foundation Trust. Stacey, the bid very much focuses on creation of model networks and technology as enablers. Could you please tell us what this means in reality?
Yeah, thank you, Clive. The bid, I hope, comes across as really, really focused about the patients, and they remain central to everything that the association wants to do. We share lots of things in common, and when we talked, the biggest issue facing lots of us after the money is our workforce gaps. And I think where the technology can really help us, and what distinguishes our bid from the things that you've heard this morning, is that we want to take our experience of using technology in other settings, so in care homes and in patients' own homes, and apply it in the acute sector. And we know from international evidence that that works. So I think that is really important. We have scarce clinical resource, in terms of the expertise. We have to distribute that resource in a different model to patients. And for us, it's all about how we create equitable models of care, regardless of where the patient may be in the system. And I guess a bit of us, feels really strongly that the only answer can't be to centralise resource in one place. That may be necessary for some high-end specialist stuff, but it shouldn't be necessary for the core district general hospital services that patients need. So we would see a future whereby clinicians aren't bound by the walls that they're used to working in, but are working across networks, doing all the standard clinical practice that other horizontal networks have talked to you about this morning, but with the added benefits of what technology can bring us, and drawing on our experience, but also drawing on the international experience that exists.
Stacey, thank you. And so finally, last but not least, to Phil Corrigan, Chief Executive, Leeds West Clinical Commissioning Group. Phil, how does the West Yorkshire Association's proposal fit with Commissioner's aspirations and what patients actually want?
Thank you. Every single CCG and every single local authority in West Yorkshire are fully behind this proposal because we think it's going to meet the needs of our patients over the next 5 years. More importantly, one of the themes that we've gathered from our patient insight, our feedback and our engagement has been that patients have said very clearly to us, before you centralise or reconfigure a service, can you please think of the most innovative technological solution that might help? And that's the driving force in part of this bid. We're not starting from scratch in West Yorkshire. For the last 2 years, we've been working on how we can sustain stroke services and how we can maximise diagnostic capability for cancer services. When Sam showed the map this morning, there was a very clear vanguard kind of presence in West Yorkshire. And we've also been fortunate to have the Challenge Fund, and we've done some pioneer work. The difference with this bid is that all those other proposals have looked at integration, particularly of records, etc., across primary care, community and social care. And this part is actually the missing jigsaw. We are absolutely convinced that if the acute trusts work together with these solutions, we will have much better local services across our 2.2 million people.
Okay, thank you. We've kept to time and now we're very willing and ready to take some questions. Thank you.
Thanks very much. Question from the table.
Thank you for the presentation. Brent McInerney, I volunteer in a social enterprise in Gloucester City. Really pleased to hear the word health inequalities are in that presentation. Really pleased to hear the word equitable models of care. And I think you probably get an idea where I'm coming from this as well, is I think we need to move away from saying we're successful to moving towards this is significant, and there is a difference between those two terms. So in terms of significance to date, could you just give me one example of how you've tackled one area of health inequality and what's the significance from that?
Thank you for the question. I think to try and bring that to life for you, so some members, 4 of the members across the association, so Leeds, Airedale, Bradford and Harrogate, have worked very recently on our stroke pathway. Long story short, for my institute in Airedale, we were unable to provide the expertise 24/7. And that wasn't equitable for our population and not what we wanted. So we've worked with our colleagues across the network to design a pathway that allowed us to keep 90% of the services locally for the patients and just focus the hyperacute bits of stroke for the first couple of days of care in other centres. And I think that got the best of both worlds for our population. And when we engaged with the population, they were nervous about changes as you'd expect them to be, but understood that that work not only saved lives and prevented disability because they were getting the expertise they needed, but made maximum use of technology because we run an acute stroke services across a number of organisations and use video conferencing or telemedicine to be able to get expertise to patients when they're back in one of our beds without the patient having to move. Another question?
Paul Holmes from Health Education England. You were very clear about the progress you've made over the past 2 years. What do you envisage will be achieved over the next 12 months?
We're all fighting here to answer that question. I think there's a couple of major shifts. I think first of all, a little bit what Stacey talked about a little bit earlier, which is perhaps the model of care that we've worked on has been a model of care which is driven by the clinician being in the institution that they're in. What we're trying to move to is that we've got a population of 2.5 million people. We want to get to a place whereby we can have the flexibility to meet need where need arises. And that's where we see the real sort of difference of being. And with the use of technology, What we should be able to see is that we can get a really nice blend that, and I think that there was a question or the point made earlier about risk stratification and where people sit. We want to use that blend with a modified approach to workforce and OD development to get to a place where we're meeting need and we don't have situations like we had in the disastrous winter that we've just had, where we can actually apply resources to where they're most needed, and we can do that in a planned way. And we think that this Vanguard opportunity could give us the opportunity to accelerate to that place.
Can I just add to that one other thing, and Owen did allude to this, it is the issue of scale really as well for us. So, well over 2 million or so, albeit geographically co-located, but nonetheless a very great geographical spread will allow us to use technology in that way and to try and learn from others, learn ourselves, and pass on that learning in terms of collaborating at scale.
Spontaneous question. So you're involved in the Vanguard, you're involved in the Pioneers, and that's on top of the day job. Can you articulate for us about how you have the leadership capacity and capability to deal, and it's not just for you, but the other Vanguards, to really deal with another point being the Vanguard?
We're all so keen, we're fighting to answer this, but Owen's going to answer this.
I think I just made the judgment today. For example, the 6 chief executives here, there's 2 of the chief executives here today because we're really clear that this is our day job. This is the future. We don't get into meeting that real challenge around health inequality and the fiscal challenge by us imagining that we've got a different day job. I don't know if you want to ask.
Just say that the CCGs absolutely believe this is the day job. This is what we focus on every single day and every week. We're not putting it off until we get the right PMO or another group of consultants to come in and advise us. This is what we do every day.
Thank you very much. Let's wish Yorkshire.
Thanks very much.